Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of November 8th, and globally, we are at almost 251 million total cases from the start of the pandemic, with over 5 million deaths, a very unfortunate landmark. In the United States, we are at almost 46.7 million total cases and 756,904 deaths from COVID. In pediatric patients, the report from the American Academy of Pediatrics dated November 4th says that we are up to 6.5 million total cases from the start of the pandemic, accounting for 16.7% of the total cumulative caseload. This also comes out to 8,641 cases per 100,000 pediatric patient. Importantly, the last now almost 2 months have shown pediatrics cases as being around 25 to 29% of the total caseload countrywide, and the last week was no different. This was 24% of the total number of new cases of COVID-19 in the United States. In Arizona specifically, again, the same report from November 4th, we are at a cumulative caseload in kids, 224,953 patients. Again, that is birth through up to age 19. That comes to 19.1% of the total caseload and 12,235 cases per 100,000 pediatric patients in Arizona. We remain at 43 deaths in this state related to COVID-19, second only to Texas, which very unfortunately has escalated to 109 deaths related to COVID-19. So those are the numbers. I think we're all aware that unfortunately Arizona continues to climb with its caseload, its hospitalizations, its deaths, and unfortunately also its pediatric cases, while other parts of the country have plateaued and or are actually decreasing significantly. So we've got still yet a bunch of work ahead of us, even as we celebrate the fabulous news that the Pfizer vaccine, 1/3 of the dose, has been issued emergency use authorization for kids from ages 5 through 11, and in fact, vaccine rollout has already started as of last week. So that's wonderful news. I'm hoping that we are all running out of and then getting more doses delivered so that we can continue this very important vaccine work. Meanwhile, a whole bunch of really excellent questions to go through this time. The first one is regarding to the deaths identified related to COVID-19 in children in Arizona, and specifically, do we know what percentage were in patients with underlying risk factors? The short answer is no, that data and that granularity of data is not available, at least not to the AAP and certainly not to me. Anecdotally, however, I think we can rest assured that a fair number of those unfortunate deaths were in patients who had additional health conditions and special needs. Certainly the several that I am personally aware of were children with special needs and reasons to have a multi-organ system or multi-organ failure. As well, it may be that the few children who have developed multisystem inflammatory syndrome in children, MIS-C, and expired as complications of that entity may also be included in those numbers. But again, I don't have the granularity of data to answer that question. It still remains true, and this is not just for Arizona, but country and even worldwide, that in general, COVID-19 is not a severe or a fatal disease for pediatric patients. That's not to say they cannot get sick, and they do, and they have, and they are, and I'm caring for them right now, as I'm sure are you. But in general, we don't look to see hugely high numbers of deaths specifically related to the virus. Next set of questions has to do with myocarditis. And the first one is just recalling that I have discussed cases of post-vaccine myocarditis as being relatively mild, resulting in short hospitalizations and resolving without long-term complications. And the question is this accurate? I mean, yes, it is. This is true. Not just based on local experience, but also based on published experience and on emerging research, sort of pre-print or pre-peer review of data that has been released, that the case series and population data that is available to us and available to me with my various contacts continues to confirm that post-vaccine myocarditis is a mild condition. If the patient is even hospitalized, it's rarely longer than a 1 or 2 day hospitalization. Patients are responding clinically to use of NSAIDs, especially ibuprofen. They're having transient elevations in their troponins and ST changes on their EKGs. And in follow-up on the longer-term studies looking at those patients, they're returning to full cardiac function with minimum of delay. Even especially not necessarily in pediatric patients, but in a case series looking at fresh Army recruits who developed post-vaccine myocarditis, a very healthy, active, and obviously physically challenged group of individuals. They also return to health and cardiac health quite rapidly within weeks to at least or at most a month. So yes, post-vaccine myocarditis, in no way to minimize what people experience if they do develop that, but it is still a very mild and certainly a survivable illness. What about the comparative incidence of myocarditis from the vaccines versus disease? And in this case, actually, we do have not necessarily comparative studies, but we do have population studies looking at both of those. So looking at the incidence of myocarditis in patients with COVID-19 versus not COVID-19, there's a 16-fold higher risk of myocarditis in the patients with COVID-19. And if you actually look at the specific risk itself, a patient with COVID-19 has a 0.15% chance or risk of developing COVID-19 related myocarditis versus a patient hospitalized with some non-coronavirus associated viral illness where the risk for myocarditis is 0.009%. So significant differences in risk of myocarditis with and without having active COVID-19. What about the risk of post-vaccine myocarditis? This actually comes to us from the CDC, data published in the MMWR. And in putting the numbers reported, which is at most, and there's a range, but at most 47 per million vaccine recipients, that comes out to a risk of post-vaccine myocarditis of, and get ready for this, 0.000047%. So, comparing that to a risk of 0.15% for getting myocarditis after the actual disease, that's, what's more dramatic than a night and day difference? It's a lot. So there is zero reason to avoid the vaccine based on a fear of getting myocarditis when the risk of getting it from the actual disease is many hundredfold higher. Okay. What about, and this is a very interesting question, is there an increased incidence of myocarditis in infants born to mothers who have been vaccinated during their pregnancy? So suggesting that the risks of the post-vaccine myocarditis might translate transplacentally or in utero in a sort of a autoimmune or molecular mimicry way to the infant. Great question. There are no reports of increased incidence. And in fact, infants born to mothers who are vaccinated in studies, approved by the American College of Obstetrics and Gynecology and published both through the MMWR as well as through Clinical Infectious Diseases, have found zero changes, zero risks, zero safety signals whatsoever in those babies born to mothers who are vaccinated during their pregnancy. So the resounding, overwhelming, recommendation by ACOG and by the AAP and everyone else, for that matter, is to proceed with vaccinating pregnant mothers during their pregnancy. Okay, let's see, where can we go next? Is it accurate to say that there have been no deaths caused by COVID-19 vaccine in pediatrics? Yep, that's accurate. All the vaccine trials of the various age groups and the various vaccine products, so specifically Pfizer and Moderna's mRNA vaccines tested with data published in 16 and up for Pfizer and 18 and up for Moderna, and now 12 and up for Pfizer. And the data, although Moderna is not yet approved, but the data has been published, and 12 and up for the Moderna vaccine, incredibly strong safety signals there, which is very important. No deaths reported from vaccine, and although the risk of death, as I've just stated, is not incredibly high with COVID-19, it's not zero. And as we'll talk about in just a little bit, the risk of long COVID in patients in pediatric patients especially, is also quite significant. So it is accurate to say there have been no deaths reported or known to the scientific and medical community in the world related to COVID-19 vaccinations in pediatrics. And this is important because the questioner goes on to say, I find that those who refuse vaccine feel that the risks of vaccine and of COVID-19 are roughly equivalent, and it's great to have talking points with which to challenge that. So we've already talked about the risk of myocarditis, so much higher with real disease. There's zero known deaths from COVID-19 vaccine, and yet the risk of death from COVID-19 in kids is not zero. So that's a significant issue. And then also are just the risks of COVID-19 in terms of time lost from school, time lost from work for the parents to care for the kids who are losing time from school. All of the other sort of additional societal and health morbidities all add up, all of which are related to actual infection, which lasts and symptomatically lasts for at least 3 to 4 days, if not much longer, compared to the risk of any symptoms after vaccination, which is at most 1 day of perhaps school lost with malaise, low-grade fever, sore arm, and myalgias. So again, those numbers are very much available to you, even by a simple Google search. Yes, I've said the dreaded name, Google search. If you look at your sources, you will find through healthychildrens.org, through the AAP, and through the CDC and NIH, some very reliable information which will help you in those talking points. Okay, let's talk about long haul COVID. Several questions about that. Children who survived moderate to severe COVID-19 illness, are there any ongoing studies or follow-up of those children for long-term symptoms of their illness, for long COVID? And there are increasing studies. I think many of us are aware that long COVID or long haulers or whatever long phrase you like to use are very much reported and a significant burden of disease in adults. What is perhaps less well known is that now there is ample evidence that it occurs in kids as well. One study, in fact, the first study on this topic comes to us from Italy, where they looked at kids aged 6 years through 16 years of age, and they found that over 50%, over 50%, had at least one symptom of their COVID-19 lasting for greater than 120 days. So 4 months with at least one symptom. And that symptom was typically quite significant because of those individuals, that greater than 50% with a persistent symptom, almost 43% of those had impairment in their life. So life satisfaction scores, ability to go to school, school performance, sports performance, all were negatively affected by that persisting symptom or symptoms, plural, in the greater than 50%. Boy, that is not insignificant whatsoever. Other studies available to us from the United Kingdom are finding a lower percentage of children and adolescents who are suffering from persistent symptoms, but it's not insignificant. So again, 13 to 14% in the most recent study from the UK and published in The Lancet found that they had symptoms lasting for at least 5 weeks. If you would like to look at a nicely written review in the Pediatric Infectious Disease Journal of 14 studies encompassing over 19,000 pediatric patients and looking at risks for incidence of severity of long-term symptoms, what they have found is that a significant minority of those children, those ages, had persisting symptoms for at least 4 and up to 12 weeks. But fortunately, after 12 weeks, many of those symptoms started to resolve and the kids returned to sort of normal life satisfaction scores. What were the most commonly reported persistent symptoms? Headache, fatigue affecting performance in sports, in walking, in life, in sleeping, cognitive dissonance, decreased concentration, inability to focus on even simple tasks, and absolutely school performance all suffered. And then abdominal pain. Interestingly, not as frequently reports, but still in there in a significant percentage, are those kids with alterations in their sense of taste and smell. And certainly I've encountered several such patients in my clinic who are 3, 4, 5 months out from their known infection and still unfortunately feel that food smells evil and water tastes like gasoline and they're dehydrated and losing weight. So yeah, this is a risk. And although the risk estimate is anywhere from 13 to up to 50%, the real numbers are probably going to settle somewhere in around the third range, so 30%, 33%, similar to the adult long COVID studies. The variability in these studies really depends on definitions and on recruitment strategies. To avoid selection bias, to avoid observer bias, one has to be very careful in how one recruits the patients. So my suspicion in the studies I've seen on the adult side that I think are really well performed, those studies have shown a risk in adults for long COVID of around a third, and symptoms lasting easily past 3 months post-infection, even up to 6 months, and unfortunately even out to a year. All right, long haul COVID, the incidence of pediatric versus adolescent versus adult. As you probably just gathered from what I just said, very difficult to give any comparative estimates because of the variability in those studies. However, and this is an important second part of this question, is there a reference for adverse effects of vaccine versus disease in terms of those long symptoms? So yes, and again, one can look in the Peds Infectious Disease Journal, one can look in Clinical Infectious Disease. I suspect we'll be seeing additional short reports coming out through Lancet and JAMA and New England Journal of Medicine, but the very brief summary of all this data coming out is that true disease, actual natural infection with SARS-CoV-2 and COVID-19 as the result, has a significant risk of long haul symptoms versus those who are vaccinated who are far less likely to have long haul symptoms. Is it possible? Yeah, it is. I'm sure if we were to look at, the next million cases in vaccinated versus unvaccinated people, we would find a couple of vaccinated people who had some long symptoms. But that is going to be just a handful compared to the hundreds of thousands worldwide that are developing long symptoms, every week. So there you go, comparative contrast. All right, I think that is it for the questions for this week. Fantastic questions. Keep them coming. And again, keep the experiences coming as well with vaccines and vaccine uptake and even questions, concerns that you are encountering in parents and your patients in regard to vaccine uptake as we look to try and move the needle for vaccine uptake through partnership with our patients, their families, with schools, et cetera, and so forth. Also, upcoming in a upcoming podcast, I'll be interviewing and chatting with Jessica Rigler from the Arizona Department of Health Services for her take on vaccine status, the COVID outbreak, and specifically with kids and where we're at. So until then, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The AzAAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. And as always, in the meanwhile, hang in there, keep smiling, keep those stories coming, and keep vaccinating. Thanks, everyone.